So this topic is one that I find tends to get the juices flowing a little bit. So what I want to do to start with is to ask you, kind of getting into it, do you have, in your experience, any formal training at some point around communicating medical errors, either from medical legal perspective or just the patient-doctor communication perspective? Is that something that you have had training in, whether in medical school, residency? Some nodding, some yes. Okay. Do you know whether you've got formal policies at University of Louisville to guide you? Okay, you're sure there are? I'm going to repeat things that you say so that people can hear. So I heard that you're sure there are, but they don't spring to mind. Right? And do you have a sense of who you would go to ask advice or get your questions answered?
Well, we hear the word risk management thrown around a lot. I've never even called them, but...
Okay, so you've got risk management, who can advise and this sort of thing. Good, okay. So I'm going to share with you some of our experience at Emory. First, I have no disclosures to make. Let me ask you this, because I like to start with it, and this is a good way for me to introduce my audience response system, which is very high-tech, and that is on the count of 3, I ask you to raise your hand and show me the number of fingers that corresponds to the answer you want all at once. It's not anonymous, but hopefully we're among friends, and I want you to feel free to speak your mind on things. The other thing to know is that as I'm going through this, I'm going to give you a lot of scenarios. Some of them will be fairly black and white. Others will have a lot of nuance. And they're chosen to have nuance on purpose because that's what life is like. And making decisions around what information to share is often subtle. So I'm trying to bring those questions out, those points out for us to discuss. All right, so let me ask you this first. On the count of 3, how many of you have seen an obvious error? 1, 2, 3. Okay, I'm looking at the VA too. I want to see some fingers up there. All right. So I'm just holding up for a sec so I can count. So almost everybody says yes. I see someone's holding up 5 fingers. Like you've seen a lot of mistakes, right? So by this point in your training, everybody has. And in fact, when I ask this of medical students at the end of their core clerkships, I'll get maybe 2/3 who'll feel confident that they've seen an error or been part of an error. And if at this point in your career you've not actually been aware of a personal error you've committed, you're probably still in the minority because it happens to us and it will happen to us. So let me ask you this. Think about these a bit. What would prevent you, the most significant thing that would prevent you from sharing this information with a patient or family about an error that you committed? So think about it a little bit, then I'll count to 3. Okay. 1, 2, 3. So raise hands for me. All right, and hold on for a second. Okay, the VA, you need to raise your hands too. All right, so I'm just going to kind of count that loud here. So I'm seeing a few 1s, a couple of 2s, a fair number of 3s. Haven't seen many 4s, and haven't seen yet. I guess I saw 1 5. All right. Okay. So some of the first 3 mostly. So feel like you need some permission from an attending or other authority figure. Okay. Medical legal concerns, and then hurting relationships with the patients potentially. Okay. If you don't mind, what I'm going to ask you to do is pause and have some dialogue at some of these questions. When it comes to number 1, because we deal with this at Emory as well. What do you think about this issue of permission? Thoughts?
You want to be on the same page because the patient's going to hear different things from different people. So sometimes you might find your attending first.
Okay, so you want to be on the same page about it, so the patient doesn't hear mixed messages. Okay, good. And how about just the decision on whether something is disclosable? Is that potentially part of it too? All right. And then what do you think some of the reasons are to tell patients and families about errors when they happen?
They deserve to know.
They deserve to know? Okay. Other reasons to tell them potentially?
I think if you're upfront about it, it's less aggravating when they actually find out the likelihood they find out from someone else.
Okay, so if you're the one telling them up front, it's potentially less aggravating to them. Okay. Good.
They're actually less likely to sue and more likely to trust you if you tell them the error up front.
Okay, less likely to sue perhaps and more likely to trust you. Okay, good. So we'll get into some of that as we go forward. All right, so here are my objectives for you. Is I want you to have a good sense of the rationale to disclose. I think now we're in a different place than we were 10 years ago when I first became the Chief Quality Officer in terms of how people feel about disclosing. And I'm going to try to give you a window into patients' perspective on this, because we've had some good feedback from patients that you'll see in this presentation. Want you to be able to describe the emotions experienced by healthcare providers as you're trying to discuss a medical error. And then I'd like you to feel like you could disclose a medical error in a compassionate and forthright way, and understand both when apology is in order and how to do that effectively. All right, so just a couple definitions before we get into the exercise. If I say that something is an unanticipated outcome, that's exactly what it is. It doesn't mean that it's an error necessarily. It's just was not expected and was a surprise. And that sometimes is a problem that still sows distrust if a patient or family member didn't feel like something was expected. An error is usually one of two types. It's either the failure of a planned action to be completed as intended. So it's an error of execution. I came up with a good plan, we didn't carry it out. I wanted to order the correct drug, but I chose the wrong drug when I was on the computer screen. The second type is kind of the error of planning or error of deliberation. It's where I'm trying to develop a plan, but my thought processes go awry, and I don't actually come up with the right plan to begin with. And then disclosure is, if we say disclosure, we're talking about providing this information of either type to the patient or family. So it's information that they wouldn't have otherwise had that we're going to be disclosing to them. Right. So I'm going to go back in time a little bit to 2007 when I was a fairly new Chief Quality Officer, and we were looking at our principles on which we were trying to operate around patient safety. And one of the things we felt was very important was transparency. If we can't be honest with patients and families about our performance, whether it's our quality scores or an error when it happens, we're probably going to be less transparent with each other and with ourselves, and not be looking at the issues, not be trying to fix the problems. So transparency was a big one for us. The other thing to know is that since about 2001, disclosing medical errors has been considered a safe practice that's among the list of safe practices, like don't give a baby to the wrong parents and that sort of thing. But it's for this reason, right? To help us find the problems. The Joint Commission added it to their requirements in the early 2000s as well. So since 2003 at Emory, we had a formal policy on the books that said when an error happens, we'll be honest about that. We'll disclose that. It was a fairly straightforward comment. But what we figured out a few years later is that it just wasn't happening. So as our risk managers would go to investigate an adverse outcome or a problem, they would then discover that no information had been shared with the patient or family, and then we're having to wrestle with this question of how do we come back and tell them information now. So we knew that the kind of dominant feeling, or at least dominant practice, was that when something happened, you didn't come forward about it, and you didn't tell people about it. So we really felt like we needed to understand the barriers to disclosure so that we could move forward and make progress with our goal of being transparent. So what I'm going to do is walk you through the exercise that we created back then, because what we wanted to do was to hear from our constituents, hear from focus groups, what those barriers are. So this is the technique we used. We created 10 scenarios that were based on our experience with real cases. We fictionalized them, we changed some facts, and we chose them to try to get at what we knew were different aspects of barriers. When I did this originally, we used red and green cards. Red was the no answer, green was a yes answer, and we did silent polling. So I worked through 10 cases, and we asked the audience, would you disclose this? And they had to go, vote yes or no. Without discussion, and that was because I didn't want the discussion from the first question to affect the answer to the second question. And then at the end, we went back through and we went through all the cases again and talked about them. So along the way, what we'll do is I'll give you a scenario. You'll have a chance to think about it and vote. We'll talk about the principles behind it, and then I'll share with you what came out of our learning from these other groups. So these were the different focus groups we used. We actually had a group of patients. We have been trying to practice patient family-centered care very deliberately, and we have patient and family advisors. Do you guys have them here at all? So it sounds like you have those available. We now have about 200 or so patient family advisors in our system. But we took one of the early groups that we had and got them together to be our panel. I had two physician groups. One was a group of primary care physicians. The other was a mixed group of specialists. We had a group of nurses from one of the hospitals, and then two groups of learners. One was, like you guys, residents at a conference like this, and then the other group was first-year medical students. Then we took advantage also of a system leadership meeting to be sure our executive leadership had their opinion heard. And then we also went to our hospital ethics committees for the two main hospitals, because they do wrestle with these kinds of discussions around specific patient cases, and we felt like they would have the most experience and they could be our expert panels. So today, again, we're going to discuss each scenario together. You'll vote on what you would do, and then we want to talk about that and learn what the issues are. And a few caveats. You'll see some things in here around orders that actually came off of paper orders back then. This was before we were on CPOE that we did these cases. All right, so let's get started with the very first case. This is a case of a near miss. Ms., I'll read these out to you, and that way everyone can hear it. Ms. N is an elderly woman with pneumonia. She tells the admitting physician she has a potentially life-threatening allergy to cephalosporins. The doctor is admitting two patients at the same time and mixes up the allergy history, ordering ceftriaxone for Ms. N. Pharmacy delivers the drug. The nurse detects the error before she receives it and calls the doctor, who is grateful that the error was caught before the drug was given. Okay. So the question for you is, should this patient be told that she almost received the wrong drug, and that if she had received it, she could have had a serious or fatal reaction? So I'll count to three. 1, 2, 3. Okay. Let's see what you think. Okay. The VA, I see some 2s. Here in the audience, I'm seeing all 2s. I'm not sure I see any. I see maybe 1. Okay. So what do you think here? What's driving your decision making and your confidence about this?
What is the patient going to gain from knowing this?
So what is the patient going to gain from the information is one comment. Others? No harm to the patient, right?
That's why we have this system, how they talk about Swiss cheese model. We talk about every bowl.
That's right. So the system worked as it should. We have checks and balances. The final check is the nurse. She caught it. So the system worked. And you mentioned the Swiss cheese. That's right. We have lots of holes, and potentially we have lots of errors that happen like this. Okay. Other comments or thoughts? All right. Anything from the VA? Okay, so what I'm going to do now is I'm going to share with you, I'll give you a graph, and I'll talk through how to interpret the graph, and then also some comments from the different groups. So when I put this graph up, this chart up in the future, what you'll see is for each group, red or green, and the proportion of red is the proportion of that group that voted no. The green will be the proportion that voted yes. So you'll very quickly get a sense of how much consensus there is within any one stakeholder group, but also the consensus across. So here, for example, you can see that people thought as you did, generally, that this is the kind of scenario where probably you don't need to disclose that to the patient. Because we were doing this to try to help guide our policy development as well. If we're going to give advice to in our own organization, where do we want to draw the boundaries and draw the lines? So some of the comments that came forward, some of the things you said, right? The system worked, you caught it. Small errors happen frequently, and actually patients knew this too. And everyone, including patients, said that if you felt compelled to talk to us about each and every little thing that goes wrong, we're going to spend a lot of time doing that and not focused on what we really care about, which is being healed, getting better. So most of the time the patients weren't that interested. Now you see that there was a small portion of patients who did want to know. And in this group, that was one person. And our patient family advisors generally are people who have free time on their hands, so they're more likely retirees. So we had a group that was mostly ages 45 and up. But this one young person was a college student who had an illness since childhood and had personally experienced a lot of errors in her lifetime. And her approach, and I think it reflects a generational difference, her approach was to say, information is power to me. I expect to be empowered. I expect to have some say in my own care. So I want the information no matter what. So sometimes you'll see her voice coming out as someone who wants the information. All right, so next question. Should an incident report be filed? 1, 2, 3. Give me your answers here. So I'm seeing mostly ones and maybe 1 or 2 twos. So thoughts here. Should an incident report be filed or not? And why or why not?
Drug made it all the way to the nurse, despite the data doesn't have it.
Okay, so the drug made it all the way to the nurse, which means that there were lots of holes in the Swiss cheese. So there are potentially lots of things to be learned from studying it. Yeah. Other thoughts?
I think it was pretty high stakes, right? Like it should have gone.
Right. So it's high stakes. The risk is high. Right. So if this is the kind of error that can slip through, this is the kind of thing that can actually kill someone. Good. So this is interesting a little bit, and I think reflects the truth. Generally, the consensus was yes. Physicians were least likely to say yes, report. And that reflects several things. Mostly what it reflects is that physicians are least likely to use the incident reporting system. They really didn't understand what it was. And back then for us it was on paper, it's now electronic. And so back then you would have to get a paper form, fill it out, you give it to the nurse in charge, and they stuck it in a folder, and then it filtered up to risk management. But the physicians weren't really aware of how to do that. And still to this day we struggle with getting physicians to report enough. Physicians will often say, well, I did report it, I told the nurse. And then it'll get through the chain that way. But physicians themselves are not using our reporting system like they should. So most people recognize that this is valuable information, and they recognize that we ought to at least be appreciating risk. So our threshold on when to report something ought to be not what happened to the patient, but what was the risk that it represented. Because these are your golden nuggets. These are the things that if you can find them and fix them now, you prevent a problem from happening later. So the barriers of reporting came out of the discussion. Fear of retribution came up. That was a real concern. And this history of incident reports being used for punishment. So at the time, these were on paper, so you would write up the incident, which got translated often to I'm writing you up. And so it had a more of a personal feel to it, and there was that concern. It takes a little bit of effort. It's a 5 or 10 minute activity. And then, this was interesting, the perception by some managers that incident reports in their area reflect poorly on them. And this was actually some new eye-opening information to us, and it reflects part of that culture of safety that is a real concern for us. That if people in charge are feeling like I can't, if something bad happens here, I look bad, that really is damaging. And I think it still is an issue for us. We have a nurse residency program in hematology oncology, in perioperative care, and in ICU care. And we were working with some of our nurse residents who, after 4 months, we said, have you seen an error? And one nurse said, yes, we started the wrong chemotherapy on a patient. We recognized it pretty quickly, so she hadn't gotten much of it at all. So we stopped it and got the right chemo, and no harm to the patient. And so we then said, well, did you report that? And she said, well, so I asked my preceptor, and the preceptor says, we don't report those kind of things around here. So that can be happening, and if that's happening in your organization, just be aware of it, and then you've got to know, what do I do, and what sort of professional courage does it take to step above that hierarchy. All right, so let's move on to case number 2. So this is an error that actually did reach the patient. This patient, Mr. E, was admitted to the ICU for pulmonary embolism. He receives IV heparin to treat the clot. On day 2, he's doing well, so they want to transfer him out to the floor, and the receiving team comes to the ICU to see the patient and write transfer orders. And this is happening around 6 p.m. So they decide, rather than using heparin, they want to switch to low molecular weight heparin because it's just easier to administer, and potentially they'll be able to send the patient home on it. So the ICU nurse, planning ahead, says to herself, I'd rather not send the patient out on an IV drip. If they're just going to start an injection on the floor, I'll stop the IV here and let them get the injection when they get out to the floor. But unfortunately, there's not a bed available right away. And at 11 p.m., the nurse's shift is over, and a new nurse comes on. And finally, the patient comes out at about 1 a.m., and then they were a little slow to take the orders off the chart. And so when the team arrives the next morning to round, fortunately, by 7:30 or 8 in the morning, they recognize this patient has not received heparin for about 12 hours. So Mr. E will probably be fine, but he is at some risk that his clot could progress since he was off the therapy. So should this error be disclosed to Mr. E? 1, 2, 3. Show me what you think. All right, so I'm seeing some 1s at the VA. I'm seeing almost all 1s here. All right, so tell me how this is different than the first case. I'm sorry?
Didn't catch the error because it already something.
Okay, so this error was not caught before it reached the patient. It hit the patient. Is that what you're saying? Yeah, that's right. So it made it all the way through. Okay. Any other thoughts about it?
Is it an error that could potentially have caused harm to the patient?
That's right. It could potentially cause harm still. Right. We don't know yet for sure that he's out of the woods, but it could still potentially cause harm. Yes.
We were actually treating him, so given the fact that the treatment has already been initiated in the patient, he should know.
Okay, so it's he was being actively treated, and this was a lapse in that therapy, so he should know about that. Any other things that come to mind that help decision making in this case? All right, so let me share with you what our focus groups thought. So here there was less consensus than you all had. You all had a lot of consensus around what to do, but this was informative in terms of the discussion. So patients were not completely clear on what to do. Right? One patient said, "Well, if it's my information, I have the right to know." Other patients kind of thought of it like the near miss and said, "Well, if there's no harm to the patient, do you really need to tell them?" So they were kind of debating this at first. But then the patient started this really fascinating conversation that flowed like this, or that got into a discussion of if they find out later, that could erode trust. So I think you had said earlier that a delay of learning they might be more annoyed, so they might be more angry. But it was really about trust. Because if you delay, they wonder, were you trying to hide it at first, and now for some reason you decided to tell them? So this relationship around trust was the main point of discussion for them. And I drew this diagram to reflect their discussion. So on one side, you didn't need to tell me. On the other side, I was kept in the dark if I found out later. And what they were saying is that which way the pendulum tips, or the seesaw tips, is dependent on their prior relationship with us and the amount of trust they've built up and established with us. One of my colleagues said that, in fact, the guy who was doing this with me, I was going around with these focus groups, he was my partner and was the director of care transformation for Emory. He's a Methodist minister by training. And he said that when you have to make a withdrawal in trust from the account, you want to have a big balance. And another patient said something interesting. He said, trust starts in the parking lot. And so we asked him to explain, and he said, if I come and I use the valet parking, and the person who parks the car is rude to me, and then I come inside and the person at the concierge desk doesn't look up and notice me, and then I arrive for to check in, and they're not giving me the time of day. By the time I see the doctor, you're behind the 8 ball. I already don't trust you because I don't think the organization is trustworthy. And that was really powerful. And it's about all the little things, the little experiences that build trust that become really important when you have an error and then potentially have to share that information. In fact, one of the patients said that he had AAA repair, and he said he could tell within about the first minute that he was in the hands of a trustworthy surgeon because of the surgeon's bedside manner. In fact, he came in the room, introduced himself, looked him in the eye, shook his hand, and said, "We're going to take good care of you." And that cemented it right there. And then asked an open-ended question, and he had that trust built up immediately. So it doesn't take long to develop trust. It doesn't take long to tear it down, and it becomes very important. All right, so let's do a different one. So can honesty potentially cause harm? So in this case, a patient has a brain biopsy that reveals CJD. This is rare and untreatable and may develop years after exposure to the causative agent. CJD is always fatal. After the surgery, the instruments are sterilized in the normal manner, even though hospital staff should have used a more rigorous process. So the CDC and World Health Organization recommendations and our hospital policy was to do either a prolonged autoclave protocol or an alkaline bath, a lye bath, prior to sterilization. However, there's no reported case in the literature of CJD transmission after normal sterilization. By the time the hospital leadership discovers this omission, 500 patients may have been operated on with instruments used on the patient with CJD. So, your question, should these 500 patients be notified of this theoretical risk of CJD transmission despite an extremely low likelihood that any of them would ever become ill? 1, 2, 3. Okay, so I see a 5. I see about half twos, half ones, I think. Okay, so this one's harder. Tell me about your thought process here. What's going on in your head as you're trying to decide? Yes?
I'm thinking about it for myself, like if I was a patient, I don't know if I would know.
Yeah, so as
it might cause more harm with more distress, more anxiety.
Putting yourself in the patient's shoes, would you want to know because it's going to cause you anxiety and potential harm from that? Okay, good. Other thoughts?
I mean, how easy is it to prove that someone has CJD? Not very. I mean, eventually, if you told them that you may have it, everybody will want to get it. That's like a huge, it's like a huge problem.
So it's hard to diagnose, you're saying? And
yeah, I mean, like you're not going to do brain biopsies on 500 of these people.
Right, you're not going to do brain biopsies.
Say that you don't have it.
Right, so you can't prove a negative in a sense. How do you tell them? Can you reassure them some way that they're not going to get it down the road? Yeah, you're right. So you're stuck there. It's really hard to do. Other thoughts? Yes?
Potentially necessary for them to know for planning purposes.
So it might be necessary for them to know for some planning purposes? Okay.
Issue down the line, or they present some illness, it'd be useful to know as a possible diagnosis in this patient should include this extremely rare disease under differential, or should buy life insurance.
So the comment for those of you who are not in the room, you should have the opportunity to buy life insurance and make other plans, including. But this is very real. The fact that you've had a potential exposure to a very rare condition may help in future diagnosis should you come down with symptoms, because it can be hard, particularly early on, to diagnose CJD. Not something we think about routinely. Yes?
I feel like it's an attorney process, because one thing is if we do our part to sterilize the things properly, it could be explained in a letter or something indicating the risk, extremely low risk, something that may have happened. I don't know. cause anxiety in a patient for sure, but it's something that would cover, in the event of something that happened later down the road, that we notify these patients.
So the fact that
Extremely low chance,
so sharing information now may provide legal protection later. You're thinking?
Well, yeah, that from both the patient and the patient perspective too. Disclose that this was not done right.
Okay, so in some sense, I'll just kind of rephrase part of it. In some sense, you're kind of showing some goodwill up front with these patients. Okay, good. So this is a tough one. Let me share with you how our different groups responded to this. When you look at this, the most striking thing that comes out of this is the patients, right? So the patient group voted initially 9-1 or so against telling them. Right? The other groups were leaning more towards telling them. The physicians were interesting. They at first said, yes, tell them, and then they started thinking about all the reasons not to when we had the discussion later on. So their initial vote was yes. So the discussion that went around was about this balance between an extremely remote risk of harm, devastating harm if it happens, but extremely remote risk that it would ever happen, balanced against a near certainty that you're causing harm through anxiety and the information itself. And so it's, even if you're trying to do the right thing, figuring out what's the right thing is hard to do because you've got these two competing good things, potentially. And what was fascinating is the arguments about this came down to sort of a philosophical debate around which approach do you take? Do you take the kind of categorical imperatives of Immanuel Kant and say truth is a good thing, you should always be truthful, or do you take more of the approach of adding up all the good that could come out and subtracting all the bad and seeing which side of the equation you're on? So that was the debate. The patients were interesting. So their initial response was to recoil. This horrified them, particularly when we told them that sometimes this is called mad cow disease when it happens in other animals. So here's what they said. The first person who spoke was a woman who said, I'm an anxious person already, and this would put me over the edge. And as she said it, she was sliding under the table in her chair. Her body language just told you how appalled she was at the thought that this could happen. And then there was some bargaining that went on. So I guess you couldn't ask the patients if they would want to know. And then another patient responded, well, what do you mean? They're going to come up to you and say, I've got a secret. Are you interested? And then another person tried to be practical. Can you keep a list of patients? And if they get sick later on, you let them know. And because they're trying to balance the harm now. But another patient said, it could be, they tell us it could be 10 or 20 years, and you never know where people are going to be. Can you count on being informed if you really get sick later? And then one person said, I guess if they found out later, they'd think you were trying to hide it. And then the room got silent, and the patients started nodding their heads. So even though they almost all voted no at first, in the end, they came around and said, I guess you have to tell them. There's not a good way out of this. You're stuck, but not telling people has real risk of harm as well. And the other thing that the patients didn't think about, and most people didn't think about, but there's also potential for harm to the institution. So think about stuff that happens in the news that makes companies trustworthy or untrustworthy. Right? Anything recently? How many of you want to rush out to your local Volkswagen dealer? Or, when you're choosing your next airline, you'll be thinking about which one do I want to fly. So there's a responsibility, if you will, to the brand. And if you are the institution and you're trying to make a policy, you have to consider what's the risk to the brand. I mean, there's a risk of letting it be known that this bad thing happened at your institution, but there's also a risk that if it's found out later, no one will trust you, even future patients who might otherwise come and seek care. So in the end, people came around and said, yeah, the right thing to do is to share this, even though it's very, very scary. All right, so here's another one that's tough. I call this one connecting the dots. So following liver transplantation, Mr. B develops internal bleeding. The resident is very attentive and manages Mr. B overnight. but doesn't call the attending surgeon. When the attending arrives 6 hours later for rounds, he rushes Mr. B to the OR, but is not able to save him. The surgeon then tells the family that their loved one's blood pressure started dropping at 2 a.m., resuscitation was given, and that he found bleeding at a suture site when they returned to the OR, and that's what happened. In private, the attending surgeon chewed out the resident for not calling him at 2 a.m., saying that when the problem started, because he says he would have operated then. So the question for you, and so connecting the dots is going from facts to interpretation of facts. Is this disclosure to the family, is the disclosure of facts adequate if the attending surgeon felt that earlier intervention could have saved the patient? 1, 2, 3. All right, so this is one where the hands aren't going up very fast. All right, so let's go ahead. Raise your hands. Commit to something. Is this adequate? So I'm seeing mostly 2s at the VA. What do you think? And some 2s. Okay, so you're 3. All right, so what are your thoughts about this one? So most of you say no, this is not adequate, but you're squirming. So what are your thoughts here? What's going on? Yeah.
Everything is clear 24 hours later.
Everything is clear 24 hours later, right? We call that the retrospective scope, right? It looks a lot clearer looking back, yeah. And what implication does that have for disclosure, do you think? So what else is going on here? What else goes through your mind?
Medicine is gray. It's not black and white. So, one surgeon might have gone in at 2 a.m., one might not have.
Okay.
You don't know the outcome.
Good. So the comment was everything is gray, and especially medicine, and you don't know that every surgeon would have gone in at 2 a.m. and have taken the guy to the operating room.
But the guy in charge of the case thought that it would.
That the guy in charge of the case thought that it would, yeah? Yeah? So that's his opinion, and he was the attending a record. So let me ask you this. How would you, or what would you say to this family if you had to phrase it some way to explain what happened?
You start with an apology.
Start with an apology, and what are you apologizing for, do you think? For not calling the surgeon? Okay.
For their loss.
For their loss? Okay.
Is this the attending talking to the family?
The attending is talking to the family. Yeah. Sorry, I want that to be clear. So the attending talks to the family, kind of tells them the timeline. Blood pressure's dropped at 2 a.m. The resident on call thought bleeding could be the cause, gave fluids immediately, ordered more blood, ordered a CT scan. Patient seems stable. Ordered follow-up hemoglobins. The CT scan gets done and gets read 15 minutes before the attending shows up. So by the time the attending walks in, they now know there's blood in the abdomen. Right. So it's perfectly clear. It's not gray at that point. Right. Perfectly clear what they have to do. Go to the OR.
Up until the CT read, it was gray.
Up until the CT read, it might have been gray. Although part of the chewing out of the resident included things like the first 3 causes of hypotension after surgery are bleeding, bleeding, bleeding. Right. So here's how it went. This was an interesting one for discussion as well, and everybody squirmed here too, including the patients as they talked about this. So among the physicians, one physician said he told them the facts. That's his obligation. And then someone else was very, very honest, and they said, if they don't ask, I probably wouldn't say anything more than that. And then another physician felt very differently. The family probably wouldn't put 2 and 2 together. Our job as doctors is to do that for people, is to help them understand the implications of the complex things that go on. That's our responsibility. Patients were interesting. One patient said, "It's a white lie, but it's a lie." And it followed up with, "and it doesn't smell good." And then the patients asked, "Will the resident be thrown under the bus?" Now the residents, that's what they were concerned about, because that's what they were living. You know, at night you're dealing with sick, complex patients. You're having to make a judgment about not only the care of the patient, but about when do I call the attending. And what the residents wanted to know is, well, what's the standard of care for me when I'm on at night versus the attending, standing there looking at the same patient? Is the standard of care different, or is it the same? And then a lot of people ask, including patients, what's the history between this resident and this surgeon? Has the resident been yelled at before? Was there a reason why they didn't call that attending at 2 a.m.? So very, very complex issues and dynamics that we're getting into the decision making about what to tell and whether to go on and explain more. And often a lot of it was around, are we opening up a Pandora's box of all sorts of messy stuff by talking more about that? So it's really hard for people to come to a consensus here, although in the end most people felt like this was not a full disclosure. All right, so here's another one for us. This is an obvious error, but an unclear link to the outcome. So Ms. L is a young woman with aggressive lupus that has not improved with high-dose steroids at another hospital. She is transferred on life support, suffering multi-system organ failure. Her prognosis is grim. The critical care team and consultants come together. They decide that cyclophosphamide is the right therapy for her, and this is ordered in an attempt to control the disease. But the order is written by the resident on the team, and they used sources to determine a dose that turned out to be 4 times what should have been given to the patient. So the patient was supposed to get 1 dose and ended up getting 4 doses before the rheumatologist figures out that the drug is still continuing. So they stop the drug, but the next day the white blood cell count drops, and then a few days later the patient gets worse and dies. So should this family be told that she received an overdose of cyclophosphamide and that it is hard to know if it contributed to her death? 1, 2, 3. So here I'm seeing ones, all right, and I see A2 and maybe some, I can't quite tell, and then some ones over there. So what are the thoughts here? Particularly if any of you thought no, you wouldn't share that. Let's talk through what makes it hard here, or what's driving your thought process. Or even if you voted yes, what would make this challenging?
I mean, there are ways to know. Like, you can actually do a causality analysis for an adverse drug reaction. And if you think that this is even if this is a possible or probable, then it's as good as saying that, yeah, I think there's an error that led to. You can say that I think that's why the white cell count dropped. I wouldn't necessarily attribute a death to it.
Okay. So we can say with some very high likelihood that the white blood cell count dropping was due to the medication. We can't say, we have less certainty about whether that caused the death.
Right. She's on life support to begin with.
Right. So her risk of death is high going in. Right. Makes it really hard to judge. Other thoughts or comments? Okay.
Kind of go along with the other things. If you don't tell them, that they might think that you're hiding something.
Okay, so there's a risk if you don't tell them and they find out later, they might think you were hiding it. Yeah, that's a risk. Yes.
Oftentimes, especially with these critical patients, like speed is important. And if you don't have access to the specialist, then there's not more you can do. It's kind of like this is what happens. That makes sense.
Yes.
Well, you might actually find comfort that if it was the lupus that caused her decline in death, that if 4 times the dose wasn't going to stop it, that there was nothing really else that could be done, even though it wasn't there. Okay. That's putting a positive, the glass half full. Right. And actually that's my mentor is a quality officer, is our system chief medical and quality officer.
And he likes to use that sort of an analogy sometimes, that you can spin anything, and so something that's a clear error, you can find the positives in it, and that's in fact sometimes what people do, is they say, well, you get 2 surgeries for the price of 1. Okay, so let's talk about how people responded in our focus groups. So this was kind of interesting here. So generally people thought, even though it's hard, we would tell. But when I did this with the nurses said no. Their vote, their gut instinct vote, was no. Any insights into that?
Yeah, they're the ones that pushed it.
They're the ones who pushed the drug. Right? But why does that make sense that they would say no, don't say anything?
They're the last person to give the checks and balances.
Right, they were the last person the error got through. So what's the implication for that, in their minds, do you think?
They would feel responsible. The guilt.
That they'd feel guilty. Okay. Yeah, so, I looked at this case and I'm thinking, this was all on the doctors. We've got a team of doctors that comes together, they make the decision, they're responsible for supervising the resident. The resident writes an order, and then the pharmacy has a role potentially in that Swiss cheese, potentially to pick it up and say, this is an unusual dose, unusual order. And all that failed. I wasn't thinking of nurses at all, but the nurses saw themselves in this. And it really brought home to me some things about nursing, professionalism, and culture that were important. So nurses have incredibly high expectations for their own performance, very, very high. They expect they will catch mistakes, and they see themselves as the last line of defense. They're also the ones who are at the sharp end of every needle. They're right there pushing the drugs, hanging the drugs, and that's a very difficult place to be for them. And especially they can feel they have so much conversation with patients and families, and they're carrying out doctors' instructions, that they can feel like they're trapped in between, and if something goes wrong, they can be blamed from both directions. And it was very, very powerful. They were unable to step back from the facts of the case to think about the principles of what's the right thing to do. It was all about what were the facts, and what steps did that nurse follow? What protocols did she follow or he follow in administering the drugs? So this was really a powerful discussion. They were very much also fearful. This is another thing that was interesting. They commented on the fact that physicians differ in how much they allow the nurse to share, how much information is allowed, as if the physicians own all the information. And that's something that's really important to recognize, is that ownership of information is up for debate when it comes to these sorts of things. And every party may feel like they own it. Now we're in competition with each other. The patient and family may feel they own this kind of information. The nurses certainly want control over it. The doctors want control over it. And the fact that physicians differ in what they allow was very important, because when things are scary like this and you're not sure what to do, what's your normal response? Is it to be wide open and share information and be transparent? No, the safe thing to do is to say nothing and do nothing. Lay low. And so one nurse said that she had been she works in a critical care unit, and she had seen a physician in the unit point his finger across the unit at a nurse and say, "You tried to kill my patient," loudly enough that all the heads turned for family members visiting their family members in the ICU. So everyone heard it. And the nurse said, from that point forward, I know that I will never share information for that doctor, and I will be very careful about sharing any information for other doctors. So now the patient has a nurse who's not useful for giving information. So this really highlighted the culture of safety for me, and how the nurses can feel very, very trapped. Another nurse said, my license is on the line. And the reality is that it can be. And there are nurses who get fired for errors. There was a pharmacist in Ohio some years ago who went to jail for an error that killed a child because a prosecutor prosecuted him, and a jury convicted him. There's been a number of nurse suicides because of medical errors that harmed a patient. So the nurses felt very strongly about this. All right, so here's another one for you. Who should do the talking in this case? So Mr. H had an internal hemorrhage, intracranial hemorrhage, and is nearly in a coma. He's brought down to radiology for an angiogram. As the team is setting up, he starts to arouse. The nurse there sees propofol in the bed and knows what it does, knows it's a sedative, hangs it, and doesn't hook it up to a pump, just turns on the dial of flow to let it drip. Okay. 5 minutes later, the patient's blood pressure falls dramatically. The rescuers identify that excessive dosing has caused the problem. They stop the propofol. The patient survives without any apparent worsening from the stroke, but it's frankly hard to tell because he was devastated from it already. So in this case, the question is, let's assume we're going to have a conversation with the family members about what happened. Who should do the talking? So should it be the radiologist who's responsible for the care in that area, plus or minus the nurse or someone from nursing in that area? Should it be the neurologist in the ICU with whom they have a good rapport, or should it be both parties together? So voting 3 here would be both parties together. So on the count of 3, 1, 2, 3. What do you think? All right, I'm seeing mostly 3s. I see a few 2s, and I see just a couple 1s. So what do you think here? Why'd you choose what you chose?
Well, I don't know. Normally the radiologist isn't there whenever the test is being done. So I didn't see why the radiologist, unless he was present and saw what happened.
Right. So the radiologist wasn't probably present, and in fact was not present. So why would they be the person, right? Okay. Yes?
So I think you have to take both ownership of the procedure and handling of the patient, so that includes both physicians.
Okay, so the perspective was that we should take ownership of the procedure and the error, and the ownership of the patient too. So having both together makes sense. Most of you chose both together. Anyone who felt differently, that it ought to be the radiologist and not the neurologist?
Does the radiologist not have a good rapport?
Does the radiologist not have a good rapport? Well, they have no relationship with this family. I can't really offer an opinion about their bedside manner, but they don't have a current relationship, whereas the neurologist does. Right? He's been taking care of the patient for several days. He's got to know the family.
The logistics of having the neurologist and the radiologist meet together to meet the family are very different.
Okay, so logistics may get in the way of being able to do this by getting everybody together. Yeah, so that's a consideration as well. So let me just share with you what people thought and what our learning was here. So purple is people who voted both. So the consensus was generally both should do this, both parties. What was interesting was that the medical residents, at least in this situation, mostly voted that the neurologist should do it. And the conversation for them was around the fact that they are the primary team. They feel like they should be in charge of communication. They wanted to take ownership and be the ones who communicated. So it was out of good motivation, but they really weren't necessarily thinking about the perspective of the radiologist in this situation. The patients were very, very clear. This was very enlightening for us. And what they said was that the relationship trumps the facts. That when we're getting this kind of news, the relationship is everything. And in particular, they said that we are, when errors happen, we are in a vulnerable position. It's scary, and we want you to comfort us and soothe us. And having a relationship that's positive is really good. And then they did say as well that, but if the physician I know who has a relationship with me, if they can't do this well and compassionately, if they're defensive, if they're angry, don't bring them in. That's the time to find somebody else. Because at this point, it's all about us as patients. It's not about you guys. And if you're defensive, if you point the finger at somebody else, then we know you're just trying to cover your own butt. And that makes us mad. You're going to take somebody who's hurting emotionally, and now you're going to make them angry because you were defensive. So this was really, really key for us to know, how do we get ready to do these sorts of things? How do we find the right people and make sure they can communicate the error in a compassionate way that's not defensive? So this is really important. There were a couple physicians who took the perspective of, And one guy said, I wouldn't touch this with a 10-foot pole, right? Not my responsibility. If it happens somewhere else, I don't want to get involved. So they're kind of being very defensive. All right. So I'm going to skip this one just because I think it doesn't add that much. It was about I'll just give you the synopsis, about what constitutes harm, basically. So this was a patient who needed a lymph node excision to determine whether their lymphoma had recurred, and also to do flow cytometry, because the markers could determine the prognosis and therefore which type of chemotherapy would be offered next. The trouble is, when they took the lymph node out, they put it in formaldehyde. Or someone handling it did, not the surgeon. And so it's no longer useful for flow cytometry. So when the patient comes in, the surgeon says, well, we didn't have enough tissue to run all the tests. So that was the definition of harm or the discussion in his mind. So the question is whether the nuance should be given. We say, no, this was a mistake, and the mistake was we didn't handle it correctly, and therefore we didn't have enough tissue. And so as people answered this, most people said we should, that was not an adequate disclosure. We should tell them what happened. And a few physicians said no. And it was kind of interesting. This was the group that was the group of mixed physicians, including some surgeons and other proceduralists. And the physician said, one physician said, there's no harm. A biopsy doesn't hurt much. And he's an ear, nose, and throat surgeon. And as he said it, he was describing how I have to do repeat biopsies all the time, on nasal masses. So I just kind of numb it up, and I put that needle up there. And as he's describing doing a needle biopsy, the rest of us are kind of cringing, imagining that. So the patients were really clear. They say, any inconvenience to us is harm. If the lab misplaces my blood sample and I have to miss work and drive back over to draw blood again, that's harm to me. So you got to think about this from the patient's perspective. So what we did was to then analyze all this discussion, and we came out with these 6 themes, and I'll walk through these a bit with you. And we've talked about a lot of these points. So trust was the first one. And to prepare for that, let me just share with you that the literature here is really fascinating to look at. Patients suffer all these kinds of emotions around medical errors. Isolation and abandonment being very, very common. Medical errors separate people. They create clefts in relationships. Patients can feel guilty. Family members can feel guilty. And the guilt is around, I should have seen this coming. I should have done something to prevent it. They can feel anger, injustice, powerlessness very often. And then, of course, fear for the future. For nurses, isolation, shame, guilt, conflict, being trapped. We heard from our nurses. And physicians, isolation, shame, guilt, anger, feeling overwhelmed, and being fearful. And hopefully by just naming them, what you see here is how much overlap there is, how much commonality there is among all parties when an error happens. And in particular, the isolation and how common that is, how shared it is. Committing an error is very isolating. Being a victim of it is very isolating. There's a wonderful video put together from the Beth Israel Deaconess in Boston about medical error, and they interview a bunch of patients. And one patient said that no one ever told me about the error, but I knew something had happened because people stopped coming in my room, and when they did, they wouldn't look at me anymore. They didn't want to talk to me. So I knew something had gone wrong. And then, the sense of guilt I've talked about already. So on the trust side, I've mentioned some of these for you. So trust, again, built on little interactions all the time. If an error happens, then if you've built a trusting relationship, you're in a better position to have a conversation about it. Patients say, we know you make mistakes. We can forgive you. You have to give us the benefit of the doubt on that. We can do that. And then this concept of if you delay, we can lose trust if we find out later. And that's a real risk. So the message there is come tell us soon. The caveat, though, is that you have to do it right. You have to have your facts in order. I don't trust that I will be supported. I remember a resident said that. And then this can't be a finger-pointing exercise. Everybody agrees on that. Patients themselves agree on it. You do not want to ever point fingers if you're having to disclose a medical error. A resident asked, aren't we putting the hospital on the hook by disclosing? And she had a background before medical school of being a risk manager for a corporate concern. So she understood risk management very well, which is all about protecting the organization. And I had to say to her, we've had a policy on the books for 4 years, and you didn't know about it. So I'm here to tell you we endorse disclosing. And then disclosure might damage the patient's trust in us. So we heard earlier how disclosing may establish trust. And the answer is that it cuts both ways. All right? The fact that someone now knows where we have clay feet could erode some trust. But it's a question of which side could be worse. So someone who's done foundational work in this area is Jerry Hickson at Vanderbilt. And what he says is always think about, if you're trying to decide should I disclose something or not, always think about what's the worst outcome that could happen if I don't disclose. And if you put yourself in a position of imagining if they found out later, would you be able to explain that? That's a really good test. On the fear side, these things we've mentioned already. The legal consequences, let me just touch on that with you for a moment. I've talked about the licensure issues, and it does vary state by state, how state boards of nursing, pharmacy, and state boards of medicine might respond. But on the litigation side, there is some research out there around this, and I think one of you had a comment that alluded to the fact that you may know about some of that research. So some of it, for example, comes out of the Lexington, Kentucky VA, was probably the first article published that showed their experience over several years of going to a proactive disclosure stance, where they not only committed to disclose medical errors, but they actually were prepared with compensation if patients were harmed. And what they found overall was that they actually paid out less in malpractice than they had under their previous policy. So overall, it went down. They compensated more people because some people who didn't know they had an error found out about that and got some compensation. So in terms of distributive justice, ethically, you were more just by disclosing because you compensated people who were harmed through an error that should not have occurred. What it does when you disclose, it removes some of the impetus for juries to award very large sums. So occasionally you'll hear about a malpractice suit in the news, and we've had several in Georgia that were like this, where the juries were mad and they took it out on the medical system and awarded huge sums, much more than could have been arrived at by settlement, because they actually wanted to punish the doctors or the hospital for what happened. So Jerry published this article a ways back, 1992. He's a pediatrician, and early in his career he studied medical legal issues. And he polled families of children in the state of Florida who had closed claims, had gone to trial or were settled. And he asked them, what caused you to want to sue? They could choose more than one thing, which is why the answers add up to more than 100%. But if you look at the list, it becomes apparent that at least 4 out of the 6, for these, the motivation to sue might be diminished by being upfront about it, right? So the first one was, the most common thing was they were advised by an influential person to sue. And often it was the next physician who they saw who said, do you realize what happened to you back there at the other place? And so it was a surprise. Or they believed there was a cover-up, or they needed information that wasn't forthcoming. I was talking to someone who works at Emory the other day who has a lawsuit against another hospital because her mother had a medical error happen, and she tried to get information about what happened, and the hospital wouldn't talk to her. She went to try to get a copy of the medical record, and they wouldn't release it. So the only way for her to get a copy of the medical record is to hire an attorney. So she hired an attorney. Or the last thing was that, maybe they want revenge. They're angry. But they're maybe less angry if you are honest as opposed to if they think you're covering it up. Now, the compensation issues for need money to provide medical care or for loss of livelihood, you can't fix that by disclosure, but you can fix that with the compensation. So on the preparation side, everyone acknowledged that we get minimal training as physicians or nurses or anyone else to do this, and advanced training only goes so far, because in the moment you also need some help to think through the case. What I've tried to hopefully get across today is how nuanced these are, how much consideration there is for what is it we're disclosing and how do we disclose it? How do we share this information? And the need for coaching in the moment. And there's some evidence that empathy training can have some effects that may reduce future lawsuits. So this is that trusting relationship and the people who can share the message in an empathetic way. So how should the disclosure be done? This is important. Start the dialogue as soon as possible, particularly as soon as the patient's aware that something happened, because you then minimize that risk of being blamed that you were delaying. However, you want to do it right. You don't want to have to come back and say what I told you before wasn't right, because now you can introduce doubt and people may wonder why you didn't have your facts together and are you changing your story. So you want to take the time to get it right and to prepare yourself to do it empathetically. Find the right messenger if you have to. Get together so you're all on the same page. Do that sort of thing. But you can start a conversation. So you don't want to do what one of my residents did one night, which was we had an elderly woman with metastatic cancer in the hospital getting PRN morphine injections. And the order was written for 2 to 4 milligrams PRN, which is no longer a legal and allowed order format. But the nurse had been giving morphine periodically. And about 2 in the morning, nurse gives a dose of morphine, and within 5 minutes, the patient stops breathing. The patient was DNR, so we didn't resuscitate. But the on-call resident gets called. She's cross-covering. And here's from the nurse, because the nurse is worried. I just gave morphine and she stopped breathing. So the resident comes in and says to the daughter, "Oh my God, we gave your mother an overdose." Well, it turns out that the patient for the last day had gotten 4 milligrams per dose without any ill effect. The nurse at 2 a.m. gave her 2 milligrams because she was in pain. And it was probably just her time to go. And it was a coincidence. But now we figure this out at 8 o'clock the next morning. We've got to call up this daughter and have a different conversation about how the information she got wasn't correct. So how do you put that in a way that's trustworthy? So you can get yourself behind the 8th ball if you are speculating, if you don't really know. So what you need to be able to say is what you know with certainty and what you don't know, and what may be never knowable. So the case of the patient who died after a cyclophosphamide overdose, we may never know whether the cyclophosphamide contributed to her death, and if so, by how much. It's not knowable. Even if you do an autopsy, it's not knowable. So we have to be clear on that. Now, apologize when appropriate. And this is a nuance, but it's an important nuance. So we can show empathy. If you were in a car accident that totaled your car on the way to work this morning, and I find out about it, I'm going to come to you and say, "I'm so sorry that happened to you." Right? I'm not apologizing. I'm expressing empathy. I understand and I feel for you. So sorry is not an apology word. When you're apologizing, you have to use those words. Say, I apologize to you. I owe you an apology. And make that very, very clear. But you don't say, I apologize when there was not an error. The apology is for a wrong that happened. And if someone simply had a bad outcome that was unanticipated, you didn't wrong them. So you want to be careful that you're not apologizing when you shouldn't apologize, because then you can send the inappropriate message. You're trying to just share with them the facts of what happened, and by apologizing, you may end up making them think there must have been an error, because otherwise, why are you apologizing? So this is a tough thing to get right. The words matter, and then following up to clarify matters a lot. In some cases, tell what's been done to improve the situation or reduce harm to others. I find, and I've gone through a lot of these disclosures trying to coach faculty members in it. In my experience, about half of families are interested in this. The other half are not at a place when you first talk about this that they want to know. They're focused more on what's going on right now. And so you sort of judge and be open, and if they're interested, tell them what can be done. And disclosure is often a process over time. It's not a single event usually. It's, here's what happened. We'll tell you more as we learn it. And we're going to be with you if you have more questions or issues that come up down the road. So let me just cover the apology piece briefly. This article by Lazari is wonderful. It's an old one, but it's a good one. So what he says is that not every apology needs these 4 elements, but that when apology goes wrong, it's usually a failure of one of these 4 areas. So the first error is acknowledge the offense. And what this means is that this should not have happened. It was wrong to have happened. So be clear about that. And so don't, if you're using passive words like, something happened, as opposed to direct words like, when we missed this dose, it put you at risk of the embolism worsening. So that's acknowledging the offense. And then validate that it was unacceptable. Say to them, that's not the care we intend to give. We should not have let that happen. And then express remorse. This is really important. They need to know that you feel it, that this is an apology with feeling. And in some cultures, remorse is, has to be demonstrated outwardly with body language and everything else. For us in the U.S., it's primarily our body language and tone of voice, and be sure to express remorse. I've got 2 grown children now, but when they were little, and if my son threw his fork at the dinner table at his younger sister, I'm going to ask him. First I'll tell him he should never do that, and then maybe ask him to apologize. And his apology often goes something like, "I'm sorry." So, his my daughter, who's 2 years younger than he was, knows right away that's not a real apology, right? So you have to get that right, and then make amends. And making amends doesn't mean pull out the checkbook. Make amends can be things like, "We're here. We're going to stay with you. I'm committed to stay with you and help you. Is there something we can do to mitigate the effects this is having on you right now? Can we control pain better? Can we provide information that you need for your family," or something like that? So making amends can just be about the relationship. So these are the elements, and just think about these as you're planning for an apology. So then care for patients and families after an event, really critical. If an error happens in the hospital, then the patient goes to rehab. Don't just let them go to rehab and don't follow up. And this is important. They love to know that we still care about them. So a phone call from the medical team or a phone call from the hospital risk manager, if they've established a relationship, as often happens in errors, that means a lot, because it's showing commitment. It's showing we took it seriously. We weren't just trying to brush them off. And it provides that ongoing human consideration. And also sometimes they have real needs that emerge, and we identify those needs. And then care for ourselves and our staff after an error. People feel terrible about it. We need to be proactive here and be not only providing help to our colleagues, but hopefully the institution has ways to offer you help if this happens. Disclosure of pitfalls. Some of these have come out in our discussion, so don't delay. My resident who said, "We gave you an overdose," that was kind of the confessional approach where she felt better after saying it, but it was wrong. The self-aggrandizement is a pitfall as well. And one of our patients brought this up. He says, I once had a doctor to say something like, "Well, we screwed up back when Dr. So-and-so was taking care of you, but I'm here now. Right, so you're in good hands with me." And he said that doesn't feel good either. Speculation we talked about, the false certainty is a problem. And I think the case where the surgeon says, "I would have come in at 2 a.m. and operated," that's a potential case of false certainty, right? It's clear in retrospect. Now you have to ask the question, because I'm not a surgeon. If you go to other transplant surgeons and say, "What would you have done in this circumstance? What's the expectation?" And if everybody says, "Yep, you got a call," then maybe we would say it was closer to being an error, not calling. And then conflict or inconsistency. So you may have experienced this already, even in the absence of errors. You've got a complex patient in the hospital. You've got the primary team and 2 or 3 consultants coming in to see the patient. You can all think you understand the disease process and are giving the same message, but often patients are hearing an individual message from everyone. So you have to really be on the same page about it. All right, and then seeking advice. You guys brought this up earlier as I was asking you. So what I would like to do, just in maybe the last 10 minutes or so, a couple quotes I like about transparency here. In the last 10 minutes or so, I want to do a little exercise with you. I'd like for you guys to pair up, and I'm going to give you a scenario, and I'd like for one of you to play the patient and one of you play the doctor. And with this scenario, you'll both know the full story, because I'm going to read one out to you and let you think about how you would have this, how you'd have a conversation and practice it. So we're going to do this for about 5 minutes, and I'd like to debrief that briefly with you. So here's the situation. So this is a patient who you've had a relationship with 6 months ago. There was a nodule on a chest X-ray, so you ordered a CT scan to go down through the adrenals to look for, as part of the nodule protocol. And the nodule did not look especially suspicious. You were recommended to repeat a CT scan in 6 months. However, on the report, there was another paragraph that said there's an incidental finding of a pancreatic mass, and this is potentially suspicious. We recommend further imaging or evaluation. So you missed that paragraph. Now you're about to see this patient for the 6-month follow-up report, and you go to the chart to prepare for the visit, and you see you've gotten a CT scan in advance that was done this morning, and the report is available to you. And as you read the report, your heart sinks because what the radiologist is saying now is that the nodule in the chest is no different, but the mass that was in the pancreas has grown. There's some dilation of the common bile duct, and there's edema around it. It's highly suspicious for malignancy. So you now are entering the room, and you're going to meet this patient. So prepare for this for a minute, and then have a conversation. All right, let me try to bring us back together. As I circulate, I think most of you have finished the main conversation. So let me just stop and ask you what kind of insights that you might have had by trying to do this. What was it like, and what insights did you gain, or what did you learn by trying?
Really difficult to do.
Difficult to do? Anybody feel like you really nailed it? And those of you who are on the receiving end, if you felt like someone did a fantastic job, please speak up and tell us what worked, what was good, or what was effective. Patrick.
So I think it's hard if you're having two conversations, so you're disclosing another error, and you're possibly also telling them that they could have cancer. Those conversations could take a whole clinic visit, and they're potentially not going to hear one half of the conversation when you tell them whatever you tell them first.
Right. Right. So just I'll repeat that for those at the VA, that you've got two kind of conversations. The conversations about the findings and the medical facts, but also the conversation around the error. And both of those could be long, complex conversations and could take a long time to do. So that's a challenge with doing this, particularly during your typical clinic schedule, right? You've got patients backing up. And that is complex, yeah. And in fact, I like another analogy from my preacher friend who was told as he was going through that, I think it's hermeneutics in theology school, when you're learning to give to preach, basically, to give a sermon. His mentor told him how you've got a dump truck full of good things to give your flock, but they come with buckets. And so you need to figure out how to fill their bucket. And that's part of the challenge. There's so much to talk about. You've got to figure out, how do I get this started? What needs to be said now, today? There's a lot to talk about. Not only now, but there's a lot that's unknown still that we'll have to talk about in the future. What part of that do I figure out how to say right now and get this started? So that's one of the challenges. And part of the challenge, Patrick, if it's all right, I'll just share what you said earlier, is that we can get into a mode of oversharing, in that we start projecting into the future and speculating about things we don't know about in terms of medical outcomes, and we start going into a lot of detail. I actually see this a lot among the residents I precept in clinic. You guys have so much information in your head. You understand the diseases and the outcomes and everything else, and you want to give that good information to your patients. But what they're capable of hearing in any moment is small, and particularly when the first news they got was devastating news. Their ability to hear the rest is challenged. So one technique that I think is really effective is actually, just like we should do when we're talking about complex illness with our patients, say something brief, stop, and pause and ask them what's going through their minds. Right? What's their reaction to that? Did they really understand what heard them say, have them, in a sense, repeat that back to you. What's their understanding of it? And then you know how to move forward with what additional information or explanation they need. Because this is challenging patient-doctor communication on steroids. This isn't just giving bad news in one direction, it's giving bad news back towards your direction too. So this is really, really challenging stuff. Other insights?
I always dread.
Yeah, the dread, I mean, this is not a good feeling to have this kind of conversation. So I do find that sometimes people are paralyzed by it. And again, just that if you're really dreading, you may find a way not to follow through. So that can be really tough. So particularly when dreading, I think it's effective to reach out and get some help, talk to someone about it. And if you've got the luxury of time, which you don't have in this case, if you've got the luxury of time, to actually practice it with somebody and make sure that what you're intending to say is what someone interprets on the other end. Because I've unfortunately even been in situations where I'm trying to have this conversation, I end up giving the wrong impression because this is hard. So it's good to run these things by people. Yes?
Proximate to when you find out about the attention. I'm wondering, in this case, I was a patient, and so, I fear that I have probable pancreatic, even though it's technically not me, actually, it's like how shut down a little bit. So, would this be a situation where it might be okay to give that information first, because that needs to be acted on immediately, and then once the person is recovered, maybe bring them back and say, I don't need to tell you that this is the second piece of this. I'm just wondering if that would be information, a lot of information, one time.
It is. So let me follow up with that. How much time, if you were in the doctor's shoes, how much time would you plan between the information about potential or likely pancreatic cancer and the error? How much time would you give that?
When would I see them again?
Mm-hmm. Okay.
I would give them some time to digest that additional information, have a plan to address what we're going to do about it. But then I think I would bring it back really quickly and say, okay, I'm now going to tell you something else about it.
Okay.
And I'm asking, is that the way to do it? Because it seems like that's a lot of stuff to throw at a person who thought they were having a CT to follow up on a
low risk nodule. Yeah. Yeah, so the question is whether it's acceptable to do it in two parts and say, okay, let's talk about the diagnosis right now and then plan to bring them back quickly and talk about the other. And I think that you could absolutely do that, particularly if you don't think you're in a state of mind to pull it off. Because of that message from our patients about do it right if you're going to do it. The danger, though, is imagine you're the patient and you're in shock right now, right? And tonight you go home and you're talking about it with your spouse, and the natural question is going to come up, say, gee, I had this CT scan 6 months ago. I wonder if it was there then. So it doesn't take long. As soon as a person's recovered from the shock, it won't take them long to at least ask that question. So I guess the next question is, even if you bring them back the next day, if they've already asked themselves that question, what are they going to think? And so you have to think about, well, can I prepare the ground for that? I want to have a follow-up conversation with you because there's really more very important things that we need to talk about with this. I mean, there may be ways to do it, but I think you have to really plan that carefully. Yeah.
I think the other issue is now patients can access their reports on the portal, so they can go back and see it right away.
Right. Patients have access to a lot more information, and it would not at all be uncommon, particularly for this kind of patient, to say, my goodness, and I'd like to be sure I get the best opinion, and can I actually have the primary records, or can I have a copy of the CT scans because I want to be able to go to this other hospital and see the surgeon or whatever. So people will get, ultimately the information will come out for this kind of thing. It's just a matter of how do I start this conversation. Yeah. So this is a really tough situation and puts you in a bit of a bind by giving you the time pressure of needing to get it started, because the patient's there to learn what was on that CT scan. And you'll have to figure out, how do we start that conversation, and how do we do it in a way that we we hopefully maintain trust, even though if I'm the doctor, I've got to tell the patient soon, if not right now, very soon, that we've made some errors. Right?
What if the patient tells you?
What if they say they're going to sue you? They could. So, and I find this is rare in my experience, that someone immediately jumps to, I'm vengeful, I'm angry, I'm going to sue. And when that happens, it's usually because they had doubt before or a trust issue before. But that can be a reaction. People could be angry off the out of the chute. So let me throw it out to you guys. How might you handle that question if that came back to you from this patient? Yeah.
Address the emotion. I understand that you're angry. I would be really angry too.
Absolutely. So validate what they're feeling. What they're feeling is natural. It's not what you hoped for, but it's natural and it's honest, and validate that. And say, I understand. And then I think you've got to, at that point, that there's anger and there's a rift in the relationship and the nature of that rift, and you then have to figure out, how do I handle that? Is there a way for me to do any repair, recovery, figure out how to move forward with this? And some patients, when they get this kind of thing, they'll be angry. They'll say, I never want to see you again, and they won't see you again. And they'll leave, and they'll go, and they'll be off somewhere else. And others won't. And a lot of patients will feel very, very vulnerable. And now they know that, they really feel like, I need you more than ever. Particularly if they have that trust, I need you more than ever. So you're going to need to be able to say that and offer that. And that's a difference that we've come to at Emory, at least, these past 10 or 15 years, because years ago, we had sort of a policy that if someone sued us, as soon as they bring a lawsuit, that's the indication that they're angry with us and they want to break that relationship. So we, at that point, tell them we can't any longer have a relationship with them. They're going to need to transfer their care elsewhere. And that, as we started doing this, we started realizing how foolish that was. It was out of that kind of medical legal mindset of once they sue us, they're always going to be angry, it's not recoverable. First of all, you don't want it to get to a suit, and maybe it doesn't have to get there. But secondly, if they sue you because you committed an error, they have right to compensation. And if they are if you're still willing and able to provide care, and they're still willing to be your patient, you may build trust and actually take the sting out of it. And maybe that helps you come to a settlement down the road for just compensation, and you don't end up with an acrimonious jury trial that, at least in the state of Georgia, takes on average 4 to 5 years to reach conclusion, which means that multiple times over those 4 to 5 years, those of us who were involved in the care are having it dredged up again. Whereas when you've got an obvious error, you can usually work to settlement within months to a year at the kind of outside in our experience. So you actually bring closure faster. And again, the experience from multiple places, not just the VA, is that on average you close it out for less money. So any other thoughts or insights or questions about the activity for today? Anything from those of you at the VA? 2 thumbs up. All right. Yes.
So this one I feel pretty comfortable in apologizing myself because it's my error and something I had control over. But when you decide to get somebody else involved, when you ask risk management to come, do you notify them for every apology you do? Those kinds of things. Like how do you interact with those?
Good question. So the question was, this is one that feels straightforward in that that you can take personal responsibility for your part in this error. When do you get risk management involved, and at what level? So this one, absolutely, because this is someone who, if it turns out, has pancreatic cancer, has a very legitimate basis to be compensated, whether that's through lawsuit or whether it's through proactive compensation. So as soon as you know anything like that's possible, you want to get risk management involved, because they go through a series of steps to actually start helping to investigate, but also they kind of open a file where you can put the information that's kept in a secure way and all that kind of thing. So you for this kind of thing, you absolutely want to get them involved as soon as possible. You may have other situations that are nowhere near this concerning. Basically our approach is we're always happy to hear from a clinician about a concern. And it may be one that they simply take a few notes. They don't open a file, but they, if you call them back later and say, I've got more information and we do need to be more concerned about it, at least they've heard about it. So generally, I would have a very low threshold, especially if you're not sure how to communicate, and now somebody with experience can help talk you through it, or sometimes talk you down. Like, I think I really need to go and say this, and they may say things like, we don't know all the facts. Can we take a step back and make sure that we understand more about this? So even in this case, even though it seems pretty straightforward, there's stuff we don't know. Plenty of stuff. We don't know the official final diagnosis. We also don't know, were there any steps taken after that first CT scan to make sure the information got to me as the doctor? Because that's a natural question. And I guarantee if you're the doctor, you go home and you think about that tonight, you're going to be wondering, what didn't I hear? Why didn't I hear about this? More than just, did the radiologist just put it in a report and expect me to see it? So you now start thinking about that. And this scenario was based on a real case. And what had happened was that the person who ordered the scan was out of town on the day the scan was done, was not reachable. They paged the doctor and couldn't get a hold of them. They found that it was ordered under the name of the nurse practitioner in clinic. So that nurse practitioner also did not answer a page. They were off that day. And so the radiologist sent an email to the nurse practitioner whose name was on the requisition and said, heads up, you need to look at this. And it just got lost, buried in that person's email while they were away on vacation. So they never responded. The doctor who ordered it never saw the email. And looking at the report, they were interested in the nodule, so their eyes went straight to the paragraph on the nodule, and they didn't read all the paragraphs that were on the report. So that was kind of the facts behind it. So at least in that situation, you could say, well, the radiologist tried, using the systems they had available at the time, they tried to contact us and do the right thing. And what it did highlight from a system learning perspective is that what we lack is a fail-safe to say when we find incidental things, because this is actually, in the literature, a big cause of medical legal risk generally. If we find incidental things, do we have a way to follow up to be sure that that we have closed-loop communication and the receiver not only got the report but understood our message with this? And our systems right now are still challenging in terms of getting that sort of feedback on it. So there's opportunity here for learning, for system redesign, for making this less likely to happen to another physician.
And a follow-up question, do you document whatever you say in the medical record?
Do you document whatever you say in the medical record? So here's the required minimum, and this comes from Medicare. So Medicare says that when there is an error, you should tell the patient, and you should document in the record that you told the patient. So that's your minimum requirement, right? There was an error in this case, you'd say there was a delay in taking action on an abnormal CT report. I shared that with the patient. So that's the minimum that that you would want to put in. You could put in more, and if you feel like you want to do that, you could, but you don't have to do that in the medical record. So what we recommend is put the minimum in the medical record, and then get with your risk management or whoever and document what you remember saying precisely for them, because that can be useful later on, particularly as if we know what we know about eyewitness testimony is true of what we hear. We may rethink it and think we told them something different later on. The patient may think we told them something other than we did later on as more facts come in. So it is useful to have that snapshot of really what did we know right then, what did we communicate right then, because later on you may not be able to remember it exactly. So that's the way we recommend it at Emory. And in this case, in particular, the case that this one came from, this was one where I was concerned that the physician First of all, the patient was not in the office when the information came to light. The patient was in the hospital when it came to light. And I was very concerned that the physician would not pull this conversation off because they were someone who was not known for their warm, fuzzy bedside manner. Also not known to be disruptive, but just in the interactions with the risk manager had been kind of cold and clipped and gave one-word answers, and at first didn't think they needed to disclose anything because it was obvious. And so I brought the person in, we had a conversation, and he wanted to take ownership and be the person to say what happened. And so I was still kind of concerned, but our risk manager went with him just to be there. She's a wonderful person in terms of empathy with patients. And she said he did the most amazing job. He sat down, held his patient's hand, and explained what happened, and took personal responsibility for his role in what happened. And the patient was grateful. The spouse was grateful for him doing that. They were upset about it. And ultimately there was a settlement that occurred out of it, but he did as good a job as anyone could have done. So I think it's often hard to know how well someone's going to be able to do, but this one worked out.